Okay, dear colleagues, some of you are still here. I will talk about NIV-NAVA implementation, and I will be short. I will just tell what is different to NAVA implementation in our unit. And we have experience from the beginning of year 2010. We started before NIV-NAVA was on the market, as we were doing user acceptance testing for the manufacturer. So we got 6 months head start. And in Uppsala, they took NIV-NAVA in use at the same time they started to trial with NAVA. And these are the 2 centers where I have used it. And here you see our numbers of patients, and you can see that they are doubling every year. So it tells something about the method, that it has found its place in clinic. The problems with NIV-NAVA, they are mainly practical. They are problems in setting up the interface. Here you see a mother who is doing it for her baby, and the nurse is helping her. And the major challenges for NIV-NAVA compared to NAVA have been related to this procedure, to the nasal piece and tubing which has been stiff, and fixation has been difficult. The other practical problem we have had with NIV-NAVA relates to eddy catheter. It has a smaller internal lumen than our regular NG tube, and that makes it difficult to aspirate through that catheter. And these patients with non-invasive support, they get air in their stomach. Babies get easily air in their stomach. They have residuals, and our everyday practice is to empty it. And with this catheter, we hear complaints about that it doesn't succeed very well. Our practice with NAVA levels is that we use 0.5 as a regular NAVA level in non-invasive ventilation. So we give smaller breaths non-invasively than invasively. This is the interface we are using in Turku, although this patient is from Uppsala. And I was quite happy with this interface. I thought it's inevitable to have problems with nasal pieces, until I saw a better one. In Uppsala, they had this kind of alternative nasal piece, which was just so much more comfortable for the baby, that now we are more unhappy with the one we are using, and we are working to get improvements in that nasal piece. This has some economical challenges, so we can't just switch to that. But what comes to the machine, it has been very easy, because we switch from NAVA to NIV-NAVA. Extubation is easy when you don't need to switch the machines. It's the same ventilator. And to keep the eddy catheter there and to get the information from it for a while after extubation, I think it is helpful for a clinician. We get information to adjust the PEEP level, and we have never had that opportunity before, and I really find that helpful. And we have the same experience as we just heard from St. Justine Hospital, that high eddy min levels respond nicely to increase in PEEP level. So with looking at eddy min levels, we adjust the PEEP level, which has been around between 4 and 6. Before we just used 4 because we didn't know what to use. And we get from eddy max levels, we get information about work of breathing, and from the trends we get information of respiratory drive. I will show only one screenshot for you, and I picked up this one because there happens to be 4 different modes of ventilation within 6 hours. So you can see the differences. This is not typical order. I will show you later what is the typical order. But this baby had eddy catheter because she had been both on NAVA ventilation and SIMV. And again, you can see that nighttime somebody who is not so comfortable with NAVA has switched her to SIMV, and in the morning when we come in, we switch to NAVA, and we see it's going well, and we are ready to extubate this baby. This baby had necrotic bowel and bowel operation, and we didn't want to blow anything in the stomach, so we tried to extubate this baby to no support at all. That's why there is this gap, but you can monitor the eddy level here during this gap also. Because of work of breathing, we saw it necessary to start with NIV-NAVA, however, for this patient, and within this period of time, you can't see any response here yet. But here you can see this typical step down to 50%, which we see all the time when you switch from SIMV to NAVA. What we typically do, NIV-NAVA has become one additional step in weaning. So we go from NAVA to NIV-NAVA, and from NIV-NAVA to CPAP, and from that to high flow cannula. And having all these steps, we can avoid easier over treatment. We can take the most baby-friendly mode of support the baby tolerates, and we have many options to choose. And when we use NIV-NAVA as a weaning step and we see how many eddy catheter days we have left, it's very cost effective. We don't need to use a new catheter for that additional step. So that is how we have implemented NIV-NAVA in our clinical practice. What has it helped us? I think we have seen few patients, a handful of patients, we feel that they had been intubated and ventilated without the extra support they got from NIV-NAVA. And we compare now CPAP and NIV-NAVA because we have never had non-synchronized, non-invasive ventilation. So I feel that some babies had got help, some babies had got away from some days on a ventilator, but as a whole, it's a small proportion of all patients we have. Another indication where we use NIV-NAVA is to try to treat apnea in patients who don't respond to only caffeine and CPAP, so that the breath in the nose may stimulate the baby to breathe the same way Merja was presenting her in her preterm case earlier today. And sometimes it helps, sometimes it doesn't. So NIV-NAVA has become one additional step on the way for these babies to home. Thank you.